My name is Manal Halim. I'm a professor of radiodiagnosis in Cairo University. And I would like to welcome Dr. Hani Fayoumi, who is a urological surgeon in Cairo University.
Thank you very much.
Thank you, sir. And we're going to start our session now by the basic in MRI of the prostate, from basic to advanced. Start very basically. First, I would like to talk about the incidence of prostate cancer. Prostate cancer is the second most common cancer malignancy to afflict men and fifth cause of death. It will give us an example. If a 50-year-old man with a 25-year expectancy, he has a chance to develop, has a 42% chance of developing the disease, but only 10% will be manifested clinically. And from this statement, we can understand that there is a clinically significant cancer and there is a clinical insignificant cancer. So how can I differentiate between clinical significant cancer and the clinically insignificant cancer? Of course, it's no single definition for this. However, the Gleason score or the PAARS try to help us by saying that if the Gleason score of the prostate cancer is 7 or more, this is a clinically significant cancer. While if the Gleason score is 6 or less, this is clinically insignificant cancer. That's the meaning of clinically significant cancer. Clinically significant cancer, that it has a potential to metastasize, to spread, and the patient will die of. While the clinically insignificant one is the one which may not have very low potential to metastasize, and so the patient will die with the cancer but not from the cancer. And the Gleason system grading, depending on of course, the macroscopic picture of the glandular pattern of a tumor. And it starts from grade 1, well-differentiated glandular pattern, till grade 5, poorly differentiated glandular pattern. While the Gleason scoring determines the histologic aggressiveness of the tumor and is the sum of two generate the score. What is the ideal prostate cancer diagnostic test? The ideal one is to identify clinically significant prostate cancer and to avoid diagnosis of insignificant clinical cancer and to have a low side effect profile. And today we're going to start with the MRI, which is a very good tool for identifying clinically significant cancer with a sensitivity and specificity about 80% as a literature. What about MRI imaging? In the past, I don't want to go a lot in the past, but in the past I was saying to our students that MRI is not useful for detection, only for staging. Nowadays, with the advances in technology and with the high technique, the MRI is really useful for detecting significant cancer, localized and characterized cancer, provide biopsy guidance, surveillance, assessment of recurrence, and part of the treatment management. I want to start with the protocol of MRI. Protocol of MRI is simple. We start first with the axial T2 weighted images, as we can see here. Axial T2 weighted images with small volume, field of volume to cover the whole gland. And as we see, this is the axial T2 weighted image. This is the bladder. This is the high intensity urine. And this is the wall of the renal bladder, which is of low signal intensity. And the prostate is well seen here. And we can see in T2 weighted images the zonal anatomy of the prostate. With the peripheral zone is the larger zone, which has a high T2 weighted images, while the central zone is the hypo-intense signal. And after we do axial T2, we do a T2 weighted images in any kind of orthogonal plane. I mean coronal or sagittal. Here is the coronal plane. This is the seminal vesicle, which is high signal intensity T2 weighted images. This is the peripheral zone, as we see high signal intensity, and as well as the central zone, which is a very low signal intensity. After we do the axial T2 and any kind of orthogonal planes T2, we do the diffusion weighted images. Diffusion weighted images should be done with a B-value, high B-value, more than 1400 seconds per milli, and corresponded with the ADC map. To let you remember the diffusion weighted images, have an example of our cases. This is an axial T2 weighted images of the prostate with a high T2 weighted images of the peripheral zone in the left side, while on the right side there is something highly suspicious here. It is a focal hyper-intense lesion seen in the right side of the peripheral zone. And we did a diffusion weighted images, and the diffusion weighted images show restricted diffusion in the same area of suspicion here, and while the corresponding ADC mapping is of low hypo-intensity or it's dark. So this is what confirm, and this area is very suspicious for us. To return back to our protocol, which started with the axial T2 and then with the diffusion weighted images, and then we take a T1 weighted image to see if there is a post biopsy hemorrhage or something, and then we go to post contrast images with dynamic contrast enhancement. After the protocol, I want to go a little bit into the anatomy details. Here is the anatomy, normal anatomy. The prostate is formed of 3 zones: peripheral zone, which is the larger zone; central zone, which is the middle zone; and then the transition zone is the smallest zone. And on MRI, here is the peripheral zone, is the larger zone, with the central zone is hypointense, as we can see. The peripheral zone should be of high signal intensity, it should be homogeneous and symmetrical. So any hypointense lesions in here is a little bit suspicious. And then I want to say also that the transitional zone, which is the transitional zone surrounding the urethra, from which the benign prostatic hyperplasia comes, and that's why it's very big here in this case, because the patient is an old patient and has a benign prostatic hyperplasia. And I want to also say that the neurovascular bundles of the prostates come from clock 5 and clock 7. What do I mean with this? The prostate is dealt with as a breast. You know, the breast we look like as a clock, 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock. So the neurovascular bundles emit into the prostate from 5 o'clock and 7 o'clock, and they are really important for the erection, for the ejaculation, and for the smooth muscle contraction. Also, I want to say something about the capsule of the prostate. Capsule of the prostate is of low signal intensity. It's rather a pseudo capsule. It's not a true capsule. It's a condensation of vibromuscular tissues. One important issue as well, if we see this schematic diagram, the prostate has a base and has a mid gland and has an apex. And if the pink color is representing the peripheral zone, from which originate about 80% of the prostate cancer, as we see here in the axial cuts, that this is the base and this is the mid gland and this is the apex, that the volume of the peripheral zone is increasing as we go from the base to the apex. So searching for the apex of the gland, to search for prostate cancer, it's really important. What cancer prostate looks like in MRI? What looks like? What the typical appearance of prostate cancers in MRI? First, as we said, it's a hypointensive focal lesion and in T2 weighted images, and it's likely ill-defined. 2, it's that we said that the 80% of the cancer originates from the peripheral zone. And 2, restricted diffusion. I mean by restricted diffusion, as I said before, it's a high diffusion weighted images and dark ADC dark, and it enhances after contrast enhancements. And this is the typical appearance of multi-parametric MRI, in which I want to see this. If I am searching for cancer, in T2 weighted images, there is a hypointense focal lesion seen in the left side of the peripheral zone, corresponded with restricted diffusion, high signal intensity in the diffusion weighted images, and with a corresponding low ADC in the DC mapping. And then when we give a contrast enhancement, the same lesion seen here took intense enhancement in the post-contrast to early and show early washout in the delayed phase. But of course, this is not always the case. This is not always easy like this. So here comes the PAARS system. What's the PAARS system? PAARS like a BIRADS. BIRADS in the breast, PAARS in the prostate, TARADS in the thyroids. So PAARS is a prostate imaging system. It's a standardization for the prostate imaging, reporting, and data system. And it's easy, it's simple. It goes from PAARS 1 till PAARS 5, where PAARS 1, there is very low incidence to have clinical significant cancer, while in PAARS 5, it's very highly likely to have present cancer prostate. So this is the lowest, and this is the highest. And then the PAARS system, version 2, there is a lot of version, one in the 2012 and one 2015, and the last one was 2019, which is the updated most version 2, and shows a scoring for the prostate cancer imaging. I mean by scoring, he made a peripheral zone scoring, and he made another transitional zone scoring. And according to PAARS, the peripheral zone, the primary sequence is the diffusion weighted images SDC mapping, while in transitional zone, the T2 weighted images is a primary sequence, and the post biopsy changes like hemorrhage and inflammation may adverse affect the interpretation. And again, to see again, this is our algorithm. This is the peripheral zone. The primary sequence is the fusion weighted images, score 1, 2, 3, 4, 5. And sometimes if 3 is equivocal, we inject the patient and it may upgrade score 3 to score 4. While in transitional zone of the prostate, the primary sequence is T2 weighted images, and here is score 1, 2, 3, 4, 5. And sometimes if score 3 is equivocal, we add the diffusion weighted images and see if it's going to upgrade the PAARS. And I'm going to not to give more than this on the PAARS. There is common benign findings still in prostate, like I said before, benign prostatic hyperplasia, which originate from the transition zone, and it shows nodules, and these nodules most likely are encapsulated, circumscribed, and with variable T2 weighted images. And it shows also variable the dynamic contrast enhancement. Other benign findings in the prostate, like hemorrhage, what we see in post-biopsy. So T1 weighted image is really important. So you see high signal in T1 weighted images, and of course the prostatitis, acute case or chronic case. But prostatitis, thank God, it looks like always like a band-like, wedge-shaped or diffuse rather than focal as a carcinoma. What about the biopsy? The biopsy. MRI plays an important role in the biopsy. We have 3 types of biopsies: systematic type, and we have the targeted type, and the inbore MRI. Inbore MRI, which is the MRI guided biopsy, but it's really sensitive, but it's costly, time-consuming, and less available. While the systematic biopsy, which is used by transrectal ultrasound, but still have a problem. Systematic biopsy, the doctor or the physician take most of it blindly, so that's why they're taking more than 10 to 12 cores. While the MRI targeted biopsy, this is a new one, or it's not that new, yani. It's the MRI biopsy, MRI target trans biopsy. After identification areas of interest in the MRI, the images are merged with the real-time transrectal sound, allowing targeted biopsies to specific lesion. What do I mean by this? I mean we take images, multiple slices by MRI, and then we determine the region of interest. And then we put the MRI images on the transrectal ultrasound images, and that's why help a lot the physician or the radiologist to target the area of interest. So MRI targeted transrectal ultrasound helps a lot in the biopsy rather than the systematic one, which was blind, and the patient has to take 10 to 12 cores and had a lot of harmful problems. Conclusion: the excellent tissue contrast of MRI can detect small lesion and differentiate clinical insignificant cancer from insignificant clinical cancer, and the MRI can guide biopsy with transrectal ultrasound fusion as well as assess the local recurrence after treatment. And now I have something else. Lastly, I would like to talk for a slide about the screening. When detected early, the prostate cancer has more than 90% cure rates. And the screening has been suggested when serum PSA level is more than 4 nanogram or abnormal digital rectal examination. Prostate biopsy is usually indicated. Now, MRI first screening was associated with improvement in the benefit-harm profile and cost effectiveness compared with biopsy first screening. And now I have an announcement. I have an announcement, a really important announcement. We are on the edge of starting our national screening program for prostate cancer in Egypt. Thank you very much. Dr. Halim,
thank you, Professor Manal, for the